So our plan here is a routine phaco and IOL insertion. The patient has a Bell's phenomenon and can't really overcome it. So we still can see the supratemporal limbus and make our side port incision. And then we can, this is a right eye. So now what do we do to be able to get the eye in a position where we do a nice job, get the planes correct to make this incision? So what I'm going to do here is I'm going to use that side port incision to position the eye. But if I just put a spatula in there, fluid will leak out and we'll lose the chamber. So what I'm going to do is lidocaine. I'm going to first put some lidocaine in the eye. And then I'm going to put some OVD in distal to the lidocaine. Wet the cornea, please. So I don't normally put lidocaine in until after I've created the primary incisions. But because of the simple ergonomics here, we're better off to go this route. Now the spatula. So now I can easily overcome this Bell's phenomenon. Position the globe exactly the way I want it and make the side, the clear corneal temporal incision very precisely. So it's just, sometimes you have to change the sequence of what you do. Wet the cornea, please. Based on, especially under topical anesthesia. So now I just injected a little bit of Provisc into the anterior chamber. Now the next thing here is capsulorhexis. I mean, you want to see great, right? But there we have some, mucoid, lid secretions, whatever. Irrigate nasal to temporal. So the technician irrigates and then good, we're done. So now we don't have that obstruction. So, setting yourself up to succeed, kind of an important surgical principle. And by that I meant, what do we have to do here? We had to get this globe into position where our visibility was excellent. Okay, so now we do the capsulorhexis, and I'm going around in a counterclockwise direction, following the curvature of the pupil. And then, we go back to our Bell's phenomenon, but that's not bad now. It's not a problem for me to see what I'm doing for hydrodissection. So now I've hydrodissected both sides, and now we'll do viscodissection for 180 degrees. So now we're ready to do the phaco. So I just stepped on the pedal with the cap on to clear it of any air bubbles. Now we'll test infusion capacity. It's not symmetric, now it is. So now we can use the chopper to position the globe. And then insert the phaco tip, position 1. Is it with the foot pedals in? So now we're ready to aspirate some OVD from on top of the lens, cortex. And now I like to put that chopper out over the equator and hold it still. The denser the lens, the more important that maneuver is. If you try to sculpt the dense lens without, wet the cornea please. So now I have to let me interrupt my train of thought here, to rotate the eye a little bit so that the light reflexes aren't in the way of my sculpting. So if you try to sculpt a dense lens without fixating it in some way, the way I've fixated this one, what you will have is a lens that resists penetration by the phaco tip, because there's no inertia. Okie doke. Those of you watching in 3D can appreciate what I call the verticalization of the chopper. So that's horizontal, but now it's more vertical. And then I bring it back to the phaco tip, quadrant removal. Now you have to have the right chopper to do that. Namely, a chopper that has a nice blunt tip, so you don't worry about getting near and touching the posterior capsule, which I do routinely with this chopper design. Oh, at the cornea. So it's a moderately dense nucleus. And the rhythm of the phaco position 3 utilization, so important. The more experience the phacosurgeon has, the less you hear bzzz, and the more you hear bzz, 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 like that. And that's really how you efficiently use ultrasound. You know, burst mode was programmed into the phaco machine in order to make it mandatory that you couldn't get continuous ultrasound unless you really wanted it. But that doesn't mean you can't do it whenever you want, just by intermittently depressing and releasing from position 3 to position 2. And that's a good thing to practice when you're not doing a case. You can, just get the feel of what's called a treadle, which is the resistance when you go from one position to the other. It can be programmed, or just the feel or the sounds of going from 2 to 3. Okay, so now we're down to cortex, subincisional cortex. Rotate the eye toward me so I could get a nice view at that subincisional cortex. And this chamber and capsular sac were maximally expanded, so it's pretty simple to execute those maneuvers. And that's subcapsular epithelium removal. And now OVD, which is Provisc injection into the capsular sac. Now right there, I want to polish the posterior capsule a bit, but the globe position is not favorable for that. Now it is, because I want to get that PSC off there, at the cornea, and I need really good visibility to do that. Good. So I'm just holding the globe where I want it, and I'm injecting OVD, and it's such a deep chamber. Good. At the cornea. So now I've got a nice clear posterior capsule, and we can just go ahead and inject the IOL. So if you're going to use topical, and even if you don't, sometimes with a block, the globe just isn't where you want it to be. So how are you going to get it there? It's your second hand, and you have to plan and practice how you're going to do that, because for sure you're going to have to do it sometimes. So there's our single piece acrylic lens injected into the capsular sac. And now it remains only for us to remove OVD. And I'm going to do it first from behind the optic and just nudge it to the side and slip the curved 90-degree INA tip under it. So now we've removed OVD from behind and now in front of the IOL. And we'll now do stromal hydration. I'm going to do that first with a little side-to-side chamber deepening. And those of you can probably, especially in 3D, you can appreciate that the optic here is actually anterior to the capsule, huh? So I'm going to go in and just depress that optic and center it real quick. Do a little stromal hydration. Check IOP. I'm checking IOP over several seconds here and it's stable. Let's see if she can look down yet. Can you look down toward your shoes? There you go. Very good. So you can see it's a smallish rexus, but that's my typical rexus. Somewhere in the 4 millimeters, sometimes 4.6, but in that range is where I like to have it. You don't get any tilting of the optic when you're covered with the capsule on top of the optic like that, and that translates into no induced coma. And we're done.